So today we'll be talking about the NICE Guideline NG133, which is Hypertension in Pregnancy Diagnosis and Management. So this was released in 2019 and updated in April 2023. It has the topics that are there in this guideline are prevention, chronic hypertension, gestational hypertension, pre-eclampsia, eclampsia, postnatal care, and long-term follow-up. So let's go over to overview and epidemiology. So 8 to 10% of pregnancies, all pregnancies are affected, and there is less than 1 in 1 million maternal mortality now from preeclampsia. Now 2010 NICE guidelines was pivotal in reducing mortality. There are three types we know: chronic, gestational, and preeclampsia. So the definitions are: chronic hypertension is present at booking or less than 20 weeks, or she's already on antihypertensives, primary or secondary in etiology. So same trigger, BP is more than equal to 140 systolic or more than equal to 90 diastolic. Now gestational hypertension is new onset hypertension presenting after 20 weeks of pregnancy without significant proteinuria. Similar, BP is more than equal to 140 by 90 after 20 weeks. Then preeclampsia is new onset hypertension after 20 weeks plus proteinuria or maternal organ dysfunction or uteroplacental dysfunction. We will talk about it later on. Trigger is BP more than equal to 140 by 90 or organ involvement. Now severe hypertension in any case, if it's gestational hypertension or preeclampsia, is BP more than 160 mmHg systolic or more than 110 mmHg diastolic. Severe preeclampsia is preeclampsia plus uncontrolled severe hypertension plus ongoing symptoms or deteriorating labs. So now let's talk about prevention. How do we prevent hypertensive disorders in pregnancy? So we'll be talking about aspirin prophylaxis, risk stratification, and supplements that are not recommended. So aspirin prophylaxis, how do we do the risk stratification? So on your first visit or whenever the pregnant patient visits you, you have to see if she has any high risk factor or any moderate risk factor. For high risk factor, one factor is sufficient. For moderate risk factors, you need more than one, that is more than equal to two factors. So if high risk factors include hypertensive disease in previous pregnancy, chronic kidney disease, autoimmune disease, SLE or antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension. Moderate risk factors include nulliparity, age more than equal to 40 years, pregnancy interval more than 10 years, BMI more than equal to 35 kg per meter square at first visit, family history of preeclampsia, multifetal pregnancy. So what do you do when you find these risk factors? You give aspirin to these patients, 75 to 150 milligram orally once daily from 12 weeks until birth of the baby. So preeclampsia, symptoms and agents that are not recommended for prevention. So symptoms, now you have to advise the woman to seek immediate review if any of the following is present. Severe headache if it's persistent and it is not responding to simple analgesia. Visual disturbances, blurring, flashing lights or scotoma. Severe epigastric pain, especially in the upper right quadrant, because that tells us that there is some hepatic involvement. Vomiting, especially with other symptoms. Sudden swelling of face, hands or feet, rapid onset. What do we not use for prevention of hypertensive disorders? We have pharmaceutical agents like nitric oxide donors, progesterone, diuretics, and low molecular weight heparin. They have no role in the prevention of preeclampsia. Then supplements like magnesium, folic acid solely for this, antioxidants like vitamin C and E, fish oil, algal oils, garlic, they don't have any role in the prevention of hypertensive disorders. Dietary, like salt restrictions, we don't have to recommend this solely for prevention of gestational hypertension or preeclampsia. Rest, exercise, work advice is same as for all healthy pregnant women. Now, how do we do proteinuria assessment? Dipstick, protein creatinine ratio, albumin creatinine ratio, and 24-hour urine. Now, as per this guideline, you should not use 24-hour urine because it's very cumbersome and there are better methods than this. So assessment of proteinuria in hypertensive disorder. So we have dipstick screening. So it says that don't use the visual reading, use the automated reagent strip reading device in secondary care settings, and then quantify if it is 1 plus or more. Now, a lot of people ask me, does NICE say is it 2 plus or is it 1 plus? Now, when I was reading this guideline, what I have understood is that when it is 1 plus, then what you do is you quantify it with PCR or ACR, because we do not rely on dipstick alone to quantify proteinuria. Always confirm. If it is 2 plus, it is a confirmation of pre-eclampsia, but even then you should definitely quantify it with PCR or ACR. So basically it is just saying that if you get 1 plus, you should definitely quantify. If you get 2 plus, it is more towards the diagnosis of pre-eclampsia. That is what I've understood from this guideline, but still there is some confusion as to does NICE say pre-eclampsia on 1 plus or 2 plus. Basically it's saying that dipstick is just, you should not rely on dipstick itself. You should do tests like protein creatinine ratio and albumin creatinine ratio. So protein creatinine ratio, if the threshold is more than 30 milligram per millimole, this is equal to significant proteinuria for preeclampsia diagnosis. If uncertain, then retest on new sample. Albumin creatinine ratio is more than equal to 8 milligram per millimole, which is equal to significant proteinuria, which is alternative to protein creatinine ratio. If uncertain, again retest on new sample. Do not use the first morning void, urine void. There is lower diagnostic accuracy. Avoid for quantification. 24-hour urine collection. See, it's very awkward. You give the patient a whole jug and you tell her that you have to collect the urine for all day, and sometimes what happens in the first morning void is that there is a lot of protein collected from the night before. So that is why we say that it delays the diagnosis. You have to collect urine for 24 hours and then see, and sometimes it does not give you the accurate results. So ACR or PCR are superior and preferred. And also proteinuria alone, interpret in context of full clinical review. It is not the only criterion for preeclampsia. So let's go on to management of chronic hypertension, what pre-pregnancy counseling, drug choices, targets, timing of birth, and postnatal care. So chronic hypertension, pre-pregnancy counseling, and drug cautions. So it is essential for women. Pre-pregnancy counseling is very important for women with chronic hypertension because they might be on ACE inhibitors and ARBs, and these increase the risk of congenital abnormalities if taken in pregnancy. So we should avoid these in pregnancy unless absolutely necessary. If pregnancy is confirmed and she is still on ARBs or ACE inhibitors, you have to stop within 2 working days and give her Labetalol, Nifedipine or Methyldopa. Pre-pregnancy, discuss switching if planning to conceive. Thiazide and thiazide-like diuretics again may increase the risk of congenital abnormalities. There is risk of neonatal complication. You should discuss alternative antihypertensives if she is planning pregnancy and advise switching before conception if possible. Other antihypertensives, there is limited evidence. No increased risk of congenital malformation is shown. Labetalol, Nifedipine, Methyldopa have established use in pregnancy. Continue existing safe treatment or switch. See treatment recommendations. That's on the next slide. So especially if you see that they are, you should offer a referral to a specialist in hypertensive disorders of pregnancy before conception to discuss risk and benefit of treatment. So chronic hypertension, treatment, thresholds and targets, and drug ladder. So continue or switch if she is on existing treatment unless systolic BP is less than 110 or diastolic BP is less than 70, or she has symptomatic hypotension. Then you should you should stop the existing treatment. Target blood pressure is less than equal to 135/85, and if she is not on any, if you have diagnosed her before 20 weeks and she is not on any treatment, you should start antihypertensives if BP is more than, systolic is more than equal to 140 and diastolic is more than equal to 90. And you should not plan early birth before 34 weeks if BP is less than 160/110 without other medical indications. So what drugs do we use? First line is Labetalol. It is licensed for use in pregnancy. Mixed alpha beta blocker, oral or IV, preferred first line. Nifedipine, calcium channel blocker, if Labetalol is suitable, but you have to check the manufacturer because some brands may be contraindicated in pregnancy. Third line is Methyldopa. More side effects, least effective of the 3. Stop within 2 days of birth because there is a risk of postnatal depression. And also you have to offer aspirin from 12 weeks onwards, and you can also do a PLGF testing if pre-eclampsia is suspected at 20 to 36 plus 6 weeks. How do we monitor such patients, and what is the postnatal care? So antenatal appointments frequency depends on the BP control. Weekly if hypertension is poorly controlled, and if it is well controlled, then you call her every 2 to 4 weeks. Fetal growth scans have to be done at 28, 32 and 36 weeks. Umbilical artery Doppler at the same time point. CTG is only if clinically indicated. Fetal monitoring, ultrasound, growth plus Leica at 28, 32, 36 weeks. Umbilical artery same. You have to do a CTG only if clinically indicated. History of severe preeclampsia, early preeclampsia, growth restricted baby, IUD or abruption. Start monitoring at 28 to 30 weeks or 2 weeks prior to the gestational age at which it occurred. Whatever severe preeclampsia or early preeclampsia occurred or IUD occurred, you have to start monitoring 2 weeks prior to which the gestational age it occurred in the previous pregnancy. Then postnatal care, chronic hypertension. BP monitoring has to be done daily, 2 days after birth, at least once between day 3 and 5 as indicated if treatment changed. Target BP is less than 140 by 90. Methyldopa should be stopped within 2 days of birth, and we should switch to alternate antihypertensive. 2-week review should be done with a GP or specialist. Review antihypertensive treatment. 6 to 8 weeks review with a general practitioner or specialist. Now, management of gestational hypertension, assessment, treatment thresholds, fetal monitoring, timing of birth, and what do we do postnatally? So, gestational hypertension, assessment and additional risk factors. Now, a full assessment has to be carried out in secondary care by a healthcare professional trained in hypertensive disorders of pregnancy. Risk factors that require additional assessment and follow-up are nulliparity, age more than equal to 40 years, pregnancy interval more than 10 years, family history of preeclampsia, multifetal disease, a multifetal pregnancy, BMI more than equal to 35 kg per meter square, gestational age at presentation, previous history of preeclampsia or gestational hypertension, pre-existing vascular disease, pre-existing kidney disease. Drug choice, again, first is Labetalol, second is Nifedipine if it is if Labetalol is unsuitable, Methyldopa if both Labetalol and Nifedipine are unsuitable. So base the choice on side effect profile, fetal effects and women's preference. PLGF testing, placental growth factor based testing if preeclampsia is suspected. The window is 20 to 36 plus 6 weeks. It helps to rule out preeclampsia. And we should not offer patients bed rest in hospital as a treatment for gestational hypertension. So management summary of gestational hypertension. So admission, gestational hypertension is divided into hypertension and severe hypertension. So hypertension is 140 to 159 systolic, 90 to 109 diastolic. Severe is more than equal to 160 by 110. So what do we do for gestational hypertension? Admission to the hospital is not routinely, don't have to routinely admit. Antihypertensive should be offered if BP is more than 140 by 90. Target BP on treatment is less than equal to 135 by 85 milligram per millimeter of Hg. BP measurement should be done, this is very important, you have to remember this, 1 to 2 times per week depending on BP. Dipstick also 1 to 2 times per week with BP. So dipstick and BP measurement is done at the same time. Blood test at presentation and then weekly. So in a week, you do BP measurement 1 to 2 times, dipstick 1 to 2 times and blood test at presentation then weekly. This is for gestational hypertension. PLGF testing once if preeclampsia is suspected between 20 to 36 plus 6 weeks. Fetal heart has to be heard, auscultation at every antenatal appointment and ultrasound and Doppler at diagnosis. If normal, it has to be repeated 2 to 4 weeks if indicated. CTG is only if clinically indicated. Now let's go on to severe hypertension. You have to admit if BP falls less than 160 by 110, then you manage as hypertension, gestational hypertension. Antihypertensive should be offered to all women. The target BP is the same, less than equal to 135 by 85. BP measurement has to be done 15 to 30 minutes until BP is less than 160 by 110. Proteinuria has to be done daily, whereas in gestational hypertension you were doing it 1 to 2 times per week. And blood tests is the same at presentation then weekly. PLGF testing once if preeclampsia is suspected. Fetal heart sound at every appointment. Ultrasound is at diagnosis and repeat 2 weeks if severity persists. Then CTG at diagnosis, then only if clinically indicated. So gestational hypertension, timing of birth and postnatal care. So you don't have to offer planned early birth less than 37 weeks if BP is less than 160 by 110. You should do it more than equal to 37 weeks. Timing is agreed between the woman and the senior obstetrician. If early birth is planned, then you should offer antenatal corticosteroids and magnesium sulfate if indicated. So what if steroids or magnesium sulfate is needed? Follow the NICE guidelines on preterm labor and birth. That will be for another class. Antenatal corticosteroids for fetal lung maturation less than 34 weeks. If it is less than 32 weeks, magnesium sulfate for neuroprotection if very preterm. Senior obstetrician involvement is very necessary for early birth decision. Postnatal care. Again, BP has to be done daily for 2 days, then at least once a day for 3 to 5, and then if indicated, if treatment changed, as indicated if treatment changed. Antihypertensives have to be continued if required. Duration usually similar to antenatal, maybe longer. Reduce the treatment if BP falls less than 130 by 80. Start treatment if no treatment antenatally if BP is more than, now remember this, if antenatally no treatment was required, and then postnatally her BP rises to more than 150 by 100, then you have to start treatment. Methyldopa has to be stopped within 2 days of birth. 2-week review if on antihypertensives. You have to go to a GP or specialist review after transfer to community care. 6 to 8 weeks review all women who have had gestational hypertension. Then management of pre-eclampsia. We have the definition, risk prediction, treatment, timing of birth, postnatal and hematological monitoring. So pre-eclampsia, as per NICE, what is the definition? Pre-eclampsia is new onset hypertension, more than 140/90 systolic or more than 140 systolic or more than 190 diastolic after 20 weeks, plus at least one of either proteinuria, PCR more than equal to 30 mg per millimole, ACR more than equal to 8 mg per millimole, and dipstick more than equal to 2 plus. Now remember, for definition, for diagnosing preeclampsia, it is more than equal to 2 plus. But if we get more than equal to 1 plus, like if you get 1 plus, then you're supposed to quantify with a PCR or ACR. So this is the difference between what was said earlier and what is said now. Maternal organ involvement, renal, creatinine is more than 90 micromole per liter, liver, ALT, AST is more than 40 international units per liter, plus or she has right upper quadrant pain. Neurological eclampsia, altered sensorium, blindness, stroke, clonus, severe headache, scotoma. Hematological platelets less than 1.5 lakhs, DIC or hemolysis, and uteroplacental dysfunction, fetal growth restriction, abnormal umbilical artery Doppler, stillbirth. Severe preeclampsia. Now, preeclampsia with severe hypertension not responding to treatment or ongoing recurring severe headaches, scotoma or nausea, vomiting, epigastric pain, oliguria, progressive deterioration in labs like rising creatinine, LFT, falling platelets, or failure of fetal growth or abnormal Doppler, that is severe preeclampsia. Now we have some risk prediction models in preeclampsia. You should consider using these validated risk prediction to guide place of care and intervention thresholds. These are online scores. There are online calculators for this. So there's a full Pies model and there is a PREPES model. Now full Pies model is validated model for risk stratifying preeclampsia patients. Used at any time during pregnancy, predicts adverse maternal outcomes, does not predict outcome for the baby. More extensively validated across diverse population. It is used to guide place of care in utero transfer interventional thresholds. Then we have the PREPES model. It is only for up to 34 weeks of pregnancy, developed using UK population data, validated in similar multinational settings, does not predict outcome for the baby. Both of them don't predict the outcome of the baby, they predict the adverse maternal outcome. So further validation unlikely. It is useful adjunct to full Pies for preterm preeclampsia. These tools assist clinical decision making, but they don't replace a full clinician assessment at each antenatal appointment, and always assess the woman and the baby independently, and offer at hospital admission if there is any concern like systolic is more than 160, rising creatinine more than 90, ALT more than 70, platelets less than 1.5 lakh, impending eclampsia, pulmonary edema, fetal compromise. Then preeclampsia management summary. So again there is hypertension, preeclampsia, hypertension and severe hypertension. preeclampsia, severe preeclampsia. So admission if concerns for the woman or baby or high risk, full Peyer's or Prepes score, and severe is more than equal to 160 by 110 BP. Admit if BP falls less than 160 by 100, you have to manage it like hypertension. Antihypertensive treatment if BP more than 140 by 90, and if she has severe, then all women. Target is 135 by 85, here also 135 by 85. BP measurement should be every 48 hours or more if admitted. Here it is severe hypertension every 15 to 30 minutes until it is less than 160 by 110, then 4 times daily. So this was every 48 hours and this is 4 times daily if she's inpatient. Dipstick is not. Now this is something that a lot of Indian settings don't practice, that even if she's preeclampsia, we'll continue doing dipstick twice a day or every day. But here what this guideline says is that only repeat if clinically indicated, if there are new symptoms or diagnostic uncertainty. Again, in severe also only repeat if clinically indicated. Otherwise, you don't have to do it every day. Blood tests twice weekly, and here this is 3 times weekly. Fetal Doppler at diagnosis, if normal, repeat every 2 weeks. This is also same. CTG at diagnosis and only if clinically indicated. Same for severe hypertension. Drug choice is same. First is Labetalol, second is Nifedipine, third is Methyldopa. You have to base the choice on prior treatment, side effect profile, fetal effects, women's preference. So timing of birth, this is very important. Less than 34 weeks continuous surveillance unless indications for planned early birth. Offer IV magnesium sulfate or plus antenatal corticosteroids in line with NICE preterm guidelines. Now 34 to 35, 36 plus 6 weeks, we have to continue unless there is any indication. When considering planned early birth, take into account the woman and baby's condition, risk factors, comorbidities, neonatal unit bed availability, and you can consider steroids. More than equal to 37 weeks, initiate birth within 24 to 48 hours. Active delivery planning, involve a senior obstetrician, discuss with anesthesia team, discuss with neonatal team if complications are anticipated. So postnatal care and monitoring in preeclampsia. So blood pressure, if she had no prior treatment, you have to do at least 4 times when inpatient and at least once between day 3, and this is postnatal care. So when she's inpatient, you have to do it 4 times daily, at least once between day 3 and 5 on alternate days until normal, if abnormal on days 3 and 5. Start antihypertensive, it is more than 150 by 100. Ask about severe headache, epigastric pain each BP time when you check the BP. So on treatment, if she is on treatment, at least 4 times daily when inpatient, every 1 to 3 days for up to 2 weeks after community transfer. Consider reducing if BP is less than 140 by 90. Reduce if BP falls less than 130 by 80. Stop Methyldopa between 2 days. Switch to alternate. Now hematological and biochemical monitoring postnatal. Preeclampsia with mild or moderate hypertension or after ICU step down. Measure platelets, transaminases, creatinine at 48 to 72 hours post birth. If normal, do not repeat. If outside reference range, repeat as clinically indicated until results return to normal. 6 to 8 weeks post birth, urinary reagent strip test for all preeclampsia patients. Proteinuria 1 plus or more at 6 to 8 weeks. Further review at 3 months to assess kidney function. Abnormal kidney function at 3 months, consider referral to specialist kidney assessment. So basically community transfer criteria, this is something that is from the RCOG guidelines or something they do in the UK. No symptoms plus BP less than 150 by 100 with or without treatment plus blood test is stable or improving. Then we come on to the most important part, eclampsia and critical care management. So magnesium sulfate, collaborative eclampsia trial regimen. So indications for magnesium sulfate. An eclampsia fit has occurred, give IV MgSO4. Severe preeclampsia and critical care, birth planned within 24 hours, you can consider. Preterm preeclampsia with planned early birth, offer as per the NICE preterm guideline. Consider if any of the following features of preeclampsia are present. What is that? Severe preeclampsia, ongoing recurring severe headaches, visual scotoma, nausea, vomiting, epigastric pain, oliguria, progressive deterioration, rising creatinine, rising LFTs, falling platelets. So loading dose, as per the collaborative Eclampsia trial, loading dose is 4 gram IV over 5 to 15 minutes. Maintenance dose is 1 gram per hour infusion for 24 hours. After the last fit, if she had a fit, continue infusion for 24 hours after the last eclamptic fit. If she has recurrent fits, then 2 to 4 gram IV over 5 to 15 minutes. Don't use diazepam, phenytoin, or any other anticonvulsant as an alternative to magnesium sulfate in eclampsia. Now, MHRA warning is that prolonged or repeated magnesium sulfate for more than 5 to 7 days, there can be neonatal skeletal adverse effects, hypocalcemia, hypermagnesemia, and monitor the neonate if there is prolonged use. Critical care, antihypertensive fluids, and HELLP. So, severe hypertension, immediate antihypertensive. Treat immediately with Labetalol, oral or IV, oral Nifedipine, IV hydrolysine. Monitor response. Ensure that BP falls. Identify adverse effects. Modify treatment. With IV hydrolysine, consider up to 500 ml crystalloids before or concurrent with the first dose, because sometimes with hydrolysine the side effect is very similar to severe preeclampsia. Fluid management, do not use volume expansion in severe preeclampsia unless you're using hydrolysine as the antihypertensive. Limit maintenance of IV fluids to 80 ml per hour unless there are other ongoing losses like hemorrhage. Epidural or spinal, do not preload with IV fluids before low dose epidural or spinal anesthesia. Combined spinal epidural. Avoid fluid overload, risk of pulmonary edema. Now there is HELLP syndrome and critical care levels. So HELLP is hemolysis, elevated liver enzymes plus low platelets. Do not use dexamethasone or betamethasone to treat HELP. So level 3 is severe preeclampsia needing ventilation. Level 2, step down from level 3 or severe preeclampsia with eclampsia, HELP, hemorrhage, hyperkalemia, severe oliguria, coagulation support, IV antihypertensives, initial stabilization, severe hypertension, cardiac failure, abnormal neurology. This is level 2. Level 1, preeclampsia with hypertension, conservative antenatal management of severe preterm hypertension, step down after birth. Mode of birth, choose cesarean versus IOL based on clinical circumstances and women's preference. Second stage, do not routinely limit the duration for controlled hypertension. Consider operative birth if severe hypertension is not responding to initial treatment. Now, fetal monitoring. How do we do fetal monitoring in chronic hypertension, in gestational hypertension, preeclampsia, severe gestational hypertension, and women needing additional monitoring? So, the summary by diagnosis. Chronic hypertension growth stand has to be done at 28, 32, 36 weeks. Gestational hypertension, it has to be done at diagnosis and if normal 2 to 4 weeks. Preeclampsia, severe gestational hypertension at diagnosis and if it's normal every 2 weeks. Uterine artery Doppler, same as 28, 32, 36 weeks. This is also the same. At diagnosis, if normal, then 2 to 4 weeks. At diagnosis for preeclampsia, severe gestational hypertension, every 2 weeks. Then CTG in all of them is only if clinically indicated, and preeclampsia and severe hypertension, you do it once at diagnosis and then if clinically indicated. Specific CTG triggers preeclampsia, severe hypertension, repeat. If change in fetal movements, vaginal bleeding, abdominal pain or maternal deterioration is there. Repeat CTG after normal at diagnosis. Do not routinely repeat unless it is clinically indicated. So women needing additional fetal monitoring, previous severe preeclampsia with birth less than 34 weeks, preeclampsia with birth weight less than 10 centile, intrauterine death, placental abruption. Start 28 to 30 weeks or more than equal to 2 weeks before the prior gestational age of onset if earlier. Repeat 4 weeks later. CTG only if clinically indicated. So intrapartum care. So intrapartum hypertension, measure BP hourly. Severe hypertension, every 15 to 30 minutes you have to measure the BP. Continue antenatal hypertensive treatment during labor. Hematological, biochemical, same criteria as antenatal. Apply criteria even if regional anesthesia is being used. Epidural anesthesia, severe preeclampsia, you don't have to preload with IV fluids before establishing a low dose epidural or combined spinal epidural analgesia. Fluid preloading risks pulmonary edema in these such patients. So second stage of labor, you do not have to routinely limit the duration with controlled hypertension, and you can consider operative or assisted birth, forceps or ventouse if severe hypertension is present in second stage or hypertension is not responding to initial treatment and senior obstetrician must be involved. Postnatal antihypertensives and bleeding and breastfeeding. Drug choice, breastfeeding safety, monitoring and advice. So postnatal antihypertensives, first line is enalapril for all except black and African or Caribbean women. Monitor maternal renal function plus serum potassium. First line is nifedipine or amlodipine if in black or Caribbean. First line is nifedipine or amlodipine if previously used successfully. Calcium channel blockers preferred in this group. Add-on, second line is enalapril and nifedipine combo. If not controlled on single drug, then add atenolol or labetalol or swap one drug for atenolol or labetalol. What to avoid in breastfeeding women. One is diuretics, two is ARBs. Prefer once daily regimen wherever possible. Women not breastfeeding, you can treat them as per adult hypertension guidelines. Breastfeeding counselling. She can breastfeed. Antihypertensive treatment can be adapted. Medication does not prevent breastfeeding. Drug transfer to milk. Most antihypertensives have very low breast milk levels, so unlikely there will be clinical effects on the baby. Manufacturer disclaimers that they lack testing data, not specific safety concern or evidence of harm. Baby monitoring. Consider BP monitoring, especially in preterm babies. Advise if there is drowsiness, lethargy, pallor, cold peripheries, poor feeding, then you should definitely show them to a specialist. Now, ACE inhibitors during breastfeeding is not absolutely contraindicated. Captopril, enalapril, quinapril may be considered in mothers of older infants if ACE inhibitors are essential. Advice at transfer and long-term follow-up. So recurrence risk, cardiovascular risk, pregnancy counseling and lifestyle. So risk of recurrence in hypertensive disorders. We have to advise a woman that overall risk of recurrence in future pregnancy is 1 in 5. That is 20%. So any hypertension, previously if she had any hypertension, so it is 21%. Previously, if she had pre-eclampsia, then any hypertension recurrence risk is 20%. If she previously had gestational hypertension, then any hypertension risk is 22%. If previously she had any hypertension, then pre-eclampsia risk is 14%. If she had pre-eclampsia, then it is up to 16%. These numbers are not that important, but it's good to know. Previous gestational hypertension, 7%. Gestational hypertension, if previous any hypertension, there is risk of 9% of gestational hypertension. Previous pre-eclampsia, she has a 6 to 12% risk of gestational hypertension. Previous gestational hypertension, she has a 11 to 15% risk. Chronic hypertension, if previously she had any hypertension, the data isn't available. Previously pre-eclampsia, there is risk of 2% of chronic hypertension. If she had previous gestational hypertension, then having chronic hypertension in the next pregnancy is 3%. So reducing recurrence risk, achieve and manage a BMI of 18.5 to 24.9 before next pregnancy, especially if prior pre-eclampsia. Recurrence risk increases if the interval is more than 10 years. Pre-pregnancy counseling, if pre-eclampsia or hypertension with birth less than 34 weeks, you have to discuss the risks and how to lower them. There are some long-term cardiovascular risks after hypertensive disorders. So any major cardiovascular event can occur there's risk of 2 times in any hypertension. In pre-eclampsia it is 1.5 to 3 times. In gestational hypertension it is 1.5 to 3 times. In chronic hypertension it is 1.7 times. Stroke, this is you just need to know, just look through this once. I don't think it will be asked in any exam, but you should know, it's good to know. Stroke risk is 1.5 times if she had any hypertension. Pre-eclampsia 2 to 3 times. Gestational hypertension risk may be increased, and chronic hypertension 1.8 times. So advise women to discuss cardiovascular risk reduction with their specialist. Smoking cessation has to be done. She has to maintain her healthy weight, healthy lifestyle. End-stage kidney disease. Now relative risk increased, but absolute risk is low. If she had no proteinuria and no hypertension at 6 to 8 weeks review, no further kidney involvement follow-up is needed. Thrombophilia screening do not routinely perform in women who have had preeclampsia. So let's go through a quick reference. Labetalol antenatal is first line. Postnatal add-on option, breastfeeding safe. It is licensed for hypertension in pregnancy. It is a mixed alpha plus beta blocker, IV or oral. Nifedipine is second line. First line postnatally in Black or Caribbean women. Breastfeeding is safe. You have to check the SPC. It may be, some brands may be contraindicated. Then it is a calcium channel blocker. Methyldopa is third line, and postnatal you have to stop within 2 days of birth. Breastfeeding, it is safe, but we are stopping it within 2 days of birth anyway. Most side effect, least effective. There is risk of postnatal depression, so stop. Enalapril, it is ACE inhibitor, so you have to avoid and contraindicate in antenatal. Postnatal is first line in non-Black or Caribbean. Breastfeeding, it is acceptable. Monitor renal function, potassium, and it is not absolutely contraindicated in breastfeeding women. Amlodipine, there is limited data in antenatal. It is first line postnatal if previously she was using this. Breastfeeding data is limited. Atenolol you have to avoid because there is FGR risk antenatally. You can add on postnatal, and there are low levels in milk. Once daily you can give the dose. ACE inhibitors, ARB contraindicated. Avoid ARBs postnatally if breastfeeding. ACE inhibitors with caution. Breastfeeding, ARBs avoid. ACE inhibitors with caution. Then thiazide you have to avoid in antenatally. Congenital risk, avoid if breastfeeding. Breastfeeding you have to avoid. Increased congenital risk, neonatal complications. Hydralazine, severe hypertension only. Postnatally, it is rarely used. Breastfeeding data is limited, and it is used IV only. Give 500 ml crystalloid with or before first dose if in antenatal period. So there are some key numbers you have to remember. 140/90 is hypertension threshold. Severe hypertension threshold is 160/110. Target BP on treatment is 135/85. 75 to 150 mg is the dose of aspirin. PCR threshold is more than equal to 30 mg per millimole. ACR, albumin creatinine ratio threshold is more than equal to 8. Significant proteinuria. 4 gram IV is the magnesium sulfate loading dose. 1 gram per hour is the maintenance dose for 24 hours. 80 ml per hour is the fluid that we give. Fluid rate we give in severe preeclampsia, and 37 weeks we have to initiate birth within 24 to 48 hours. This is the same that we have already learned. Drug ladder is Labetalol, Nifedipine, Methyldopa. Drug ladder postnatally is enalapril or Nifedipine or amlodipine. In Black or Caribbean women, you can add Nifedipine or enalapril, add or swap atenolol or Labetalol. So management at a glance, clinical decision flow. Chronic hypertension, pre-pregnancy counseling. You have to stop whatever drug is she's using if it is not compatible with pregnancy. Start treatment if BP is more than 140/90. Target is 135/85. Drugs, Labetalol, Nifedipine or Methyldopa. Aspirin 75 to 150 from 12 weeks. Scan 28, 32, 36 weeks. PLGF if pre-eclampsia is suspected. No early birth less than 37 weeks if BP is less than 160/110. Postnatally, daily BP for 2 days. Review at 2 weeks plus 6 to 8 weeks. Gestational hypertension, secondary care assessment, trained professional treatment if BP is more than 140/90. Target is 135/85. Not severe, no routine admission. Weekly BP plus blood. Severe, then admit 115 to 30 minutes BP. PLGF if preeclampsia is suspected. Fetal ultrasound and diagnosis. Repeat 2 to 4 weeks. No early birth less than 37 weeks if BP is less than 160/110. Postnatal, you can reduce it to if it is less than 130/80 and start treatment if it is more than 150/100. Preeclampsia, you have to admit if clinical concerns are there or there is a high full Payas or PREPES score. Diagnosis, treat if BP is more than 140/90. Target is 135/85. Severe, 15 to 30 minutes. BP till less than 160/110, then 4 times daily. Blood tests have to be done 2 to 3 times weekly. Magnesium sulfate if eclampsia or features of severe preeclampsia. Less than 34 weeks and surveillance plus magnesium sulfate. 37 weeks, birth within 24 to 48 hours. Postnatal labs and BP review at 2 weeks plus 6 to 8 weeks. Advice about cardiovascular and recurrence risk. So thank you. This was the NICE guideline on hypertension in pregnancy. You can follow me on Instagram, the Healing Neuron, the same name as my YouTube channel. And this was based on the NICE Guideline NG133, which was updated in April 2023 and published in 2019. Also remember, this is for educational purposes only. If you have preeclampsia or you have a raised BP antenatally, then you should definitely visit your OBGYN. And this is not for treatment purpose, only for educational purpose. And thank you, and I'll see you in the next video.